All right, I'd like to welcome everyone tonight to our fifth HCMA sponsored COVID town hall meeting. And tonight I'm happy to introduce four panelists who have taken their time to join us tonight. Many of them, if not all of them, are very familiar to our members, and I will be introducing them in just a minute. For those who are joining us, you probably have been in part of some kind of Zoom meeting in the last 9 to 10 months. But just as a reminder, if you would like to have a question or like to present a question to the panelists while we're discussing and talking tonight, put the arrow on the chat icon at the bottom of the screen. The chat box will open, and where it says type message here, you type your question and press enter, and we can all see it. And at the appropriate time, I will be looking through these questions and submitting them to the panelists. My name is Dr. Mike Cromer, and I'm the president of the HCMA, and happy to be able to present our panelists for tonight. We have Dr. Margarita Cancio, an infectious disease specialist here in town, and also does both inpatient and outpatient infectious disease work, as well as some work with transplant patients, which she will be discussing later on. Dr. Kimmy Kim with USF and Tampa General. Welcome, Dr. Kim. Dr. John Sennett, epidemiologist and infectious disease specialist at USF and Tampa General. And Douglas Holt. Dr. Holt is the medical director. I know there's another name for that, but medical director of the Hillsborough County, Florida Department of Health. So welcome, Dr. Holt. Okay, we have some pre-presented questions that we can get to in just a minute. But Dr. Sennett, I'd like you to first just to give us an update on vaccines in general. A little bit update if there's been any change on the vaccines that have been emergency approved by the FDA, made by Moderna and Pfizer. And then more insight, if you have any, on the Johnson & Johnson vaccine. And I'll turn it over to you at this time.
Sure. Any of y'all on with me, feel free to chime in. It's a rapidly changing area, and people, have access to newer information. In general, Pfizer, BioNTech, and Moderna are on the market. They're both RNA, mRNA vaccines. Their mechanism of action is that they code for the spike protein, okay, the piece of RNA. And that messenger RNA is injected and it's taken up by a muscle cell. And that's good. Muscle cells are long-lived, probably as long as your body. And there, it rests in the endoplasmic reticulum and is translated from RNA to the spike protein with both Moderna and Pfizer. So we only have 9 months of experience, but antibody levels have remained high with both products through 9 months. Theoretically, these vaccines in animals have lasted 2 to 3 years. The Johnson & Johnson product is a different product. It's an adenovirus-associated vaccine. We've been doing research with adenovirus vectors. Adenovirus is a double-stranded DNA virus. The advantage is it's quite sturdy. It was isolated from adenoids in 1953. It infects a variety of tissues, so it's actually good as a carrier of genes. For 3 years now, we've been using adenovirus vaccines on patients with hemophilia. And we've found that they last 3 years so far, which is impressive beyond belief. The rate of totally preventing disease with Johnson & Johnson is about 66%, but it does prevent serious disease at least 85% of the time, and also it lowers the death rate to almost negligible. The advantage of the J&J vaccine is it's one shot, and it's durable. You can keep it in your freezer for 2 years or in your refrigerator for 3 months. And that makes a huge difference. Pfizer requires -80 to -90, which will give you an electrical bill you won't believe after a month. The Moderna requires -20 to -30. Both of those vaccines theoretically should last years, but we don't know. And what I find important is how incredibly potent Moderna and Pfizer are. You can dilute plasma 25, 30, almost 50 times, and it still kills the virus. So these are much more potent than natural infection. And that's why people that have had COVID should still get vaccinated. They will get 25 times greater protection after they're vaccinated.
You made a comment about this vaccine should last 3 years. You mean the vaccine itself or the antibody response to the vaccine?
Well, it would be the antibody response to the vaccine. You would be protected about 3 years, I think.
Yeah.
That's our experience with the adenovirus.
Yeah.
But it could be different for this. And we have different strains arising all the time, which is a different issue.
So along those lines, the people that still were involved in the initial, I think it was 40,000 people in the Moderna and Pfizer vaccine studies, they're following those along for antibody levels still. Are they still showing good levels here at 8 or 9 months out?
Oh, yes. Excellent. Okay. 9 months out.
Good. Johnson & Johnson vaccine being a one-dose series and also much less stringent storage requirements. Do you foresee that be the type of vaccine that probably the majority of not just the United States, but the world population will get? Or is it too hard to tell right now? It hasn't even been emergency approved yet, I know.
Yeah, we can make some predictions about that. It's about $4.50 to make each, okay? The true cost of manufacture. Pfizer, BioNTech, their true cost, including bottle, label, and everything, for just to make it is $40 a vial. Moderna's $38. Johnson & Johnson is between $4 and $5. The Oxford AstraZeneca is less than $2. It might even be $1.20. So globally, I think AstraZeneca, Oxford, is going to come into wide use and it's easily stored. But with resistance in South Africa and in the P1 strain in Brazil, that vaccine might have to be modified.
There's some general question that was submitted, and you mentioned the effectiveness of the first two vaccines, 93, 94, 95%. What can we as physicians tell our patients as far as what if you're in that 5%? Do we tell them that, hey, you still have some protection, and if you do get the virus, it's not going to be as deadly or strong disease, strong an illness than if you didn't get the vaccine? Is there anything we can tell them as far as that 5% goes? That's
exactly what I tell them. I say no vaccine is really 100%. With a massive exposure, it just isn't going to work. Now, what it will do is it will prevent you from going to the hospital of that 5%, okay, that do get infected. Very few will go to the hospital and none will die. So these are effective, at the end point of preventing disease is 95%, which is fantastic. It's a miracle because those are all comers. You just walked in and got the shot. You could have been immunosuppressed. You could have had cancer. You have a low white count. Still 95% were protected. So I think that people that still get infected are actually I actually think in my experience they're better than 95%. And it's 95% even in patients that aren't very healthy.
Okay. Another question local physicians have been having to handle, not knowing a good answer, is there have been some fear and some true happenings of people having a delayed second dose. We know that there's a window, but what if the window becomes broader and someone is, say, a week late or 2 weeks because of availability or because of crowds or because, let's say, something happens to them that they can't get their vaccine? Is there going to still be some protection when they get that second dose, no matter when it is? Or at some point, do they need to start over?
Probably after 90 days, they would need to start over. And this is the state of Florida. It's inconceivable they would make a mistake of any type whatsoever. But if they did, this would be one they'd make. My advice is there is no exact scientific answer. What I do is give these people a second shot, and then I'll measure an antibody level afterwards to make sure that that was adequate.
Okay.
And that's you can easily handle people outside the window.
Since we're still on the actual vaccine topic, a question came in. Do you know anything about the company Altimmune and their desire to start studies with a nasal vaccine?
I know a little about it. I think that that's a very interesting idea. The virus predominantly, in fact, at least 90% of the time, is actually acquired through the nose and Kieselbach's plexus. And the vaccines we're giving now stop the systemic issue. It would be nice to stop it
It's point of entry.
nose if we could with a topical vaccine that would produce IgA. IgA is very effective at killing viruses. There aren't any vaccines of that nature out there that I'm aware of. It's a novel idea. I think that in 2 years, we're actually going to be having cocktails of vaccines. And I would tell you that right now, people laugh at me, but I take the flu vaccine IM, and I also take it intranasally because I just don't want to get the flu. And if somebody offered me an intranasal thing for COVID, I'd take it too, hoping to cut 95 to 98%.
So you get maximum protection from both.
Yes.
Thank you. Hey, Dr. Kim, one topic or issue that's arisen since our last town hall meeting has been the issue of viral variants. So I was wondering if you could spend a little bit of time and educate our members on what you know about the variants, the potency, the presence of it, especially here in Florida, and vaccine coverage of the variants.
So there's a bunch of different variants, and the thing that all of us epidemiologists, infectious disease people know is that you have a lot of viral particles, and the longer they're circulating out there, they're going to naturally have mutations and things like that. They don't mutate as frequently as influenza and things like that, but we knew that they would mutate, and that indeed has happened. And obviously, the virus that's going to be selected for are ones that are potentially more transmissible. And unfortunately, that seems to have been the case in a bunch of independent phenomena, including the UK variant. And then there are independent mutations in the virus in the spike protein that allow it to interact with host cells, the ACE2 receptor, and those mutations seem to make the virus more transmissible and more infectious. And then there also is some evidence coming out, probably just because it's more infectious, but we don't quite know the details, where the virus may well be associated with more deaths. So there's the UK variant. They're all numbered, according to nomenclature that genomics people use to show how related viruses are. And so there's a variant that is pretty much taken over the UK. There's another variant that's in South Africa that is also starting to go through South Africa, and that variant also, is spreading through South Africa. There's another version in Brazil, and it looks like with the vaccine, because the vaccine gives you very, very high titer antibodies. For at least the UK variant, the protection is really quite good, and I think that you shouldn't worry about that at all. For the South African variants, there's a little bit more concern. So the efficacy of the vaccine seems to be more like maybe 60% and stuff like that. And then when people have looked in the lab, what you can see is that the antibodies elicited by the vaccines neutralize the virus a little bit worse. The UK variants, the South African variants, probably 6-fold less. There's also a variant out in California that has some of the same mutations, but we don't, have characterized all that well. Here in Florida, I think it's mainly this UK variant. So that seems to be most common in California and here. I think certain countries like the UK have been very proactive about sequencing viral isolates. So they know what the distribution of virus is here. That's a relatively new effort here in the US, but I think most of us would predict that these variants will become more predominant, especially in Florida, where we already have, several hundred cases that we know of. But I think at least for this UK variant right now, the news for the vaccine is good, that everyone who takes the vaccine and gets an appropriate regimen, they should be protected. Obviously, we're all very worried about other variants and that may turn up. And I think Dr. Sinnett's probably right in that we're going to probably have to get boosts with the newest version of what's around, similarly to what we have, say, for the flu vaccine.
Mm-hmm. Okay. Yeah, so as you alluded to, it's a nature of the beast for the variants to occur, for mutations to occur, and that's just part of the problem of containing this, and will add to the prolongation of this epidemic. Correct?
Correct.
Yes.
And I think this is where the more viruses that are out there, the more chances there are for mutations. So this is why people are waiting for the vaccine. All the public health measures that we've been using, social distancing, masking, and stuff like that, really continue to be extremely, extremely important, because this virus it's very infectious to begin with, but these variants, most of them tend to be more infectious. And so we need to do everything that we can to protect our community and our loved ones, even if, we expect the vaccine, for all of us to get the vaccine very soon.
All right, thank you. And Dr. Holt, being our local representative for the Florida Department of Health, and being an integral part of many committees as far as the implementation of the vaccine rollout, could you talk a little bit about, first of all, just local statistics? How is Hillsborough County looking here over the last 2 weeks? Was there a Super Bowl spike? And then talk a few words on how the rollout is going in general in Hillsborough County, and I may have some specific questions to follow up after that. Go ahead.
Yeah, if our epidemiology looks good, but we're still in a extraordinarily high amount of viral transmission. We are seeing an average of 400 cases a day, 7-day average. That's down from our peak of 1,000 that occurred in early January. We are still well above any threshold that suggests the virus is having anything other than widespread, highly active transmission. Our positivity rate, while down, is also at 7%. They're still significantly above where we would want to be. So, we've made progress, but we're still way up high in the mountain. And as far as the Super Bowl spike, it's really a relatively short period of time, nothing that I can detect and attribute it to a Super Bowl. When you're up with this many cases, it would really take a lot to noticeably attribute that. But we're in about a week or so, the next week or so. If there's going to be a big increase, it'll come around this coming week, or we're into that.
So far, the only spike you saw related to the Super Bowl was after Gronkowski's first touchdown. That's my dad joke for the night. Okay. All right. Talk about some of the vaccine rollout and the thing we all saw on the news at University Community. What happened there at University Mall? I mean, what happened there and what has been done to correct that?
Yeah. So I think again, I think we've all lived through the vaccine rollout, which we've gone through several phases. Early on, the governor focused on our hospitals, a lot of that, again, because of the Pfizer product. And early on, the focus on healthcare. He then very dramatically and suddenly on December the 23rd announced that he was going to put anyone 65 and older into the top category as far as vaccine. And that resulted in a statewide scramble for us from the health departments to try to put some type of access available for the general public, essentially. And our county, we've experienced three different contractors that we have engaged, three different appointment systems. We are currently with a statewide system that, was bought with lots of promises. I've come to hate that analogy about we're flying a plane while we're building it, but that's by far of what's happening. So they spoke about an idea that anybody could go online and pick among many sites for your vaccination, and none of that was ready out of the box. We were one of 5 counties, essentially were beta testing it. So it was real problematic just with our first doses. What you saw recently at University Mall was a confluence of first dose pretty close to their capacity, and they tried to roll second doses into that same site, side by side, if you will. When they first rolled out their first doses at the state site, which would be the week of January 18th, initially the thought and what was indicated was you would come back to that site at your appropriate time. The state Department of Emergency Management basically changed the process and required an appointment, but that was not really very communicated at all. And so people, some made appointments, others showed back, and all of that together created a worst case scenario where the backups were a mile long, and they stayed open till close to midnight, I think, or something, trying to at least get through those that were there. Going forward, the system is gradually improving. They now are enabling people to make their second dose appointment on site there to give some assurance. But more importantly, the state has plans to move and expand. So we're going to be moving away from University Mall into, right now it's either going to be Raymond James or HCC. There's discussions between the city and the county and the state about where, and we're hoping and expecting a second site to take the load off, which will be either a state site or also a federal site has also been proposed. So if we can get that type of access, then I think some of the ability to get a vaccine will be diminished. Oddly, at this time, we actually have a fair amount of Pfizer vaccine for the drive-through because, again, they haven't been able to really ramp up full capacity. So what I've been doing over the last few weeks is trying to work with my partners, including Dr. Cancio, hospitals, USF, some of the larger practices that can receive large amounts of Pfizer, so I can get somebody else to be able to give the vaccine. And we're going to keep doing that as long as there is surplus vaccine that the state drive-through isn't able to administer. We'll work through our medical partners. The county has, we are involved in a targeted effort, which is really going into those that are have a hard time accessing the vaccine at the drive-through sites. Some of our low-income senior housing, Tampa Housing Authority and others. So we've been doing those for a couple of weeks. They range in size from 100 to 300 or 400. And then we're doing churches to get some vaccine access to minority groups, and hoping to be able to get into some of the South County and some of the areas with our Hispanic communities in addition. So it's a combination of the state public access, medical providers in their settings, and then what I would call our sort of targeted approach. We did have, and we'll probably continue, we did have some invite vaccine efforts, one for the dental community a week ago. We did some home health aide nurses and or home health workers. So we're going to continue to do those as we can. And so that's kind of where we are right now. The limitation for my county is Pfizer. If I had Moderna, I could certainly provide more vaccine to more community practices. And I'll stop there.
Okay. At our last COVID town hall meeting in December, right when the first vaccine was getting emergency approval, we were told as community doctors and as HCMA members that if we wanted to be vaccinators and be able to vaccinate our patients, all we had to do was, and this was also upon the direction of Scott Rifkes, the Surgeon General of Florida, all we had to do as providers was make sure we registered on the Florida Shots website, and then, that would be our only avenue. And it seemed like probably because of the order by the governor to make sure the over 65 population gets vaccinated first and fairly quickly, all the vaccines are going to these big sites, and the small community physicians who have registered on Florida Shots haven't seen anything or any communication. Any feedback on that? When may that happen?
Yeah, I mean, what we in our conversations we had with the group, I think initially, I fully anticipated that the only way I could provide or we would provide locally was through a direct agreement through the health department here. Did not envision that the quantity of vaccine that would be available would be sufficient to come, and basically you just order it off to Florida Shots, which is what the concept was, but that it requires basically a almost a full supply of vaccine, and it also can't be Pfizer. So what is governor's choices has been is to direct the vaccine to, as you've seen, community pharmacies. Also, the federal government have used that. When would you be able to order through Florida Shots at a community physician and get supply, I think that's when they're going to be the Johnson & Johnson, AstraZeneca, and other products. It certainly won't be Pfizer. And the Moderna supplies, while increasing, really, when we started this initially, there was an idea that we would start with a trickle, and then it would go to a stream, and then we would have rivers of vaccine. I don't have any more vaccine than I had the first week of January in this. They are promising more, but that I've heard that. So it is frustrating to our community physicians. I don't have a solution, but I don't want to present an unrealistic expectation that being registered in Florida Shots is going to start yielding deliveries to your offices anytime soon.
Don't make any promises to our patients on that. Okay. Clarify what you just said. You don't have any more vaccine than you had the first week of January. Did you mean all that we've had has come in that first week and no more? Or
No,
the amount that came that week are the same, the amounts that are coming in successive weeks?
Yeah, I'm talking about the first doses. So the amount I have for the first doses that I had in January 4th at the first time is essentially the same amount that I have weekly that comes in to provide this state drive-through site. They do
Is that number public knowledge? How many is that?
We get under the old system, which was 5 doses per vial, which I kind of liked because I could always skim off the 20%. It was 11,700, but in fact, that's 14,040 doses, I believe, if the math serves me correctly. So we get 14,000 doses that come in. The county drive-through should be running at 2,000 doses a week or day for 7 days. They're really closer to about 1,600 or so, and that varies. So that's where that extra vaccine, if you will, a couple of thousand doses a week that I have been providing to some of our community medical partners and also into those targeted events for our hard to reach minority type of populations.
Okay. Among the community physicians who have met the requirements of forming a pod, point of distribution, is Dr. Cancio. And Dr. Cancio, you're the only one among us that had to put together a vaccination site on your own and at your office, I believe it was. Can you give us your experience on that and some things that we as community physicians need to know on being a pod?
Number one, we're very grateful to the health department and Dr. Holt for giving us that opportunity. This effort was in conjunction with the Hillsborough County Medical Society and the Florida Physician Alliance. The original goal was to try to vaccinate the healthcare workers that in our offices that had no access to vaccines. And that was organized that way. We had one site at Dr. Martha Price, and she did a number of vaccines at her office, and she has given both first and second doses. Our office has now given close to 2,000 of the first dose. And this week we're finishing up the second dose for those patients. Then we will start again next week with first dose. We have learned a lot, and and now we have a better process. At the beginning we didn't know exactly what to do, but we have learned. We have the Pfizer product. So we have to make sure that it's used properly, meaning that when we pick up the vaccine from the health department, it has to be used within 4 days. So you have to do a lot of scheduling, and you get 6 vaccines, 6 shots from each vial. So you have to schedule all of this. You can give a lot of shots at once. One of the challenges that we quickly learned is that this program had to be done at the same time that you were seeing your patients in the office. So you had your office staff, your regular patients that needed to be seen. We also have infusion. We have several things happening in the office, and we had all these vaccines. So, and it requires a lot of manpower because you have to, we had to figure out a way to make sure that the phone calls were not coming to our office. And that still is a problem, even though if you call the office, it tells you, please do not go to the website to register yourself. They keep on calling to the point that some of our patients are upset now that they're not getting their calls answered. So that has been a little bit of a challenge. Then the next thing was, how do we divide manpower from the office and be able to run this site, because we're running things at the same time. We did have to develop with our IT group, and it has been so many people working together. The IT group put together in our website a way to get all the paperwork done, to register and get all the paperwork done, so that people will be ready when they come, because you have to have information, you have to have the consent form, the consent to treat. I hope there's about several pieces of paper that have to be ready by the time you come in. And then we decided to do a drive-through, and we had to get signs. I mean, it sounds strange, but we had to have signs, cones, tables, chairs. We even had to have a pod outside so that we could put everything that we were doing for the vaccine drive-through in some kind of place where it was accessible, quickly done in the morning and taking it away. And then there was the manpower, and I have no words to thank Dr. Mark Smith and the volunteers. We had a group of retired physicians, Dr. Rashkin, and actually under the leadership of Dr. Mark Smith and Peggy and Maureen Ogden. Maureen Ogden was one of the vice presidents from Tampa General that has retired, and she organized the nurses, and Dr. Smith organized the physicians, and both of them. And basically we ran it with volunteers. There's a couple of staff members that my office that go out there, but I couldn't be doing this without them. It's just not possible. Because you have to run your practice, and you cannot, if you put, and it requires a lot of people. You have to control, you have to schedule them. We can't have, we have to schedule them. All the paperwork has to be ready. You have to make sure that everything's in the computer, because you have to report it, which is really important. Then you need somebody to do the traffic control, review the paperwork person by person. Then the injections have to be given, and then the patients have to be monitored. We have bought clocks, little clocks that have a magnet, and we put it inside the car, and they makes a noise when you're ready. Then we go and check up on you. So we get them, so we have had to do that, the drive-through. Somebody has to draw all these vaccines, and it may sound simple, but like, for example, the health, it comes with a 5 cc syringe. We thought that we were better with a 3 cc syringe to draw all the stuff to prepare the vaccine. And then we do get 6 vaccines out of every vial, like you're supposed to. And we always have the same person drawing everything, but that's one person that has to be done. And then we put them in little ice buckets and take them out. once it's drawn, you have to use it within 5 hours. So we have to have a process. Everybody has to be very aware. We have to have different needle sizes for depending on the person, because this is an intramuscular vaccine. It is not a subcutaneous vaccine. So it has to be intramuscular. So it has been, I mean, we have learned a lot. We are doing it, but we could not be doing it without the volunteers. And we're very thankful to them for helping and getting, and then my staff mainly focuses on trying to do the paperwork and the reporting for Florida shots, and that to make sure that the state and our area gets credit for all of these vaccines that are being given. What we chose to do is that when the patients come through, we give them the card. We have even had to make some cards. We didn't have enough, so we actually went out to, and got some more cards. So we made the cards and we give them the card, and we're doing 3 weeks of vaccine 1, and 3 weeks later, we don't do vaccine 1, we do vaccine 2. So if you had your vaccine on Tuesday at 3 o'clock, you get your number 2 on 3 weeks later on the same time, and we tell you exactly, and we give them the paperwork as they go, and that way you don't have to reschedule people. That would take a tremendous amount of time. We have gone through thousands of patients in the that have signed up in our website. So we have had healthcare workers, many healthcare workers from lots of the offices, not only the offices that are part of both Hillsborough County Medical Society and the Florida Physician Alliance, but we have had dental offices. We have had other offices that have had no access. We have had requests for example, from a couple of churches that take care of African Americans, and we have done those. And then we have our patients, and then those that have signed over 65 in our website. And we try to, schedule equally. And we already very much scheduled for the next 3 weeks are going to be those number 1. And we have probably 2 weeks already fully scheduled as much as we can do. So the big message is that you really have to plan it. Number 1. Number 2, it does require resources. Do not be mistaken. It's not like you can just not, it requires resources to do it. Obviously, all of this is free. You cannot charge a patient. Medicare will pay for the vaccine 1 and 2, but you have to have the number, and it takes so long that it may not be practical to do. I mean, it's just, maybe you can do it in your office. If you do 5 or 6 vaccines, you can do that. But in a drive-through, there's just no time to do that. So we have we're not, it's very hard to do that. And then the other thing is that we're committed that not a single vaccine will be wasted. So we schedule everybody, we plan it clearly, and we can proudly say that not a single vaccine has been wasted. And we have given them all, and we'll give, this week we'll finish giving the second. We are ready for another 6 weeks with our incredible volunteers, which we couldn't do without them. But if somebody has a specific question of how we have done that, I'm happy to answer or help whoever, because it is an important thing to do. But it has to be done while you're seeing all your other patients as well.
As president of the HCMA, I have gotten some feedback from community physicians who are not on staff at hospitals, and or even if they are, okay, well, they have not been able to get their staff vaccinated. And I think I heard you say that is one of the priorities of your pod, is to vaccinate physicians or healthcare workers, whether it be physicians or dentists or chiropractors, and their staff. Now, some of the people who are HCMA members have submitted a form to the FPA and have not heard back anything yet. What can we say to them? Just wait, you will be in touch with them?
Well, we only have, like I said, we have done
2,000.
The list is in the thousands. We have done a lot. And like, for example, I can tell you over the next 2 weeks, there are more than 200 healthcare workers already scheduled. But so we're doing as many as we can, and as well as doing the other groups that we have been asked to do. But we have done a lot, and we have a lot of schedule, but the demand is definitely
Outweighs the availability. Yeah.
I mean, you can only, and it is impossible to do it without scheduling. And obviously the list is quite large. I know that there is some planning to try to do at least one day of another drive on a different location. Hopefully we can get to some more of those, but it is, but we have a long list, and we're working through it in the best way we can. And actually, Dr. Henderson's office has been very helpful with that one. So, so many different people have been trying to work on this. Dr. Reed has been very involved. It's just a number, so many need vaccine.
I want to thank you, the FPA, and Dr. Price for really going the extra mile. Dr. Mark Smith and all the volunteers, thank you for helping get our healthcare workers protected. Along those lines, along a vaccine question, maybe directed back to Dr. Holt. Dr. Cantu, you said as people leave, they were told when to come back, second dose. Some of our patients, and a question that came in on the chat line is, at the University Mall Clinic, they were told that they would be called when the second dose is available and to come in. Some of them have not been called, and it's been over 3 weeks. What do you suggest that they do? If they got their first dose at university.
Right. Then the options that they have are to go into the website, the myvaccinefl.gov, and essentially reschedule or indicate that you need a second dose. I'm told that they're trying to look out for those to prioritize, to try to catch those that they missed during that period of time. That's, they don't really have the helpline, and others it doesn't work for that.
Right.
They're trying to, as I mentioned, they've changed their process so that now you actually get an appointment when you get your first shot. That literally started, I think, yesterday. So it's not going to help those that unfortunately were caught in that period where they changed basically what their expectations were.
Okay, so there's a place on the website that there can be, you can leave a comment that, hey, I got my first, not my second. It's not just a registration page.
Yeah, you essentially go back in and re-register.
Re-register, okay.
But when it gets down, you say, I need my number 2 dose instead of your first dose.
Okay.
So that we have gotten some patients calling our office because of that, and because we have had it so organized, first and second dose, we have said that we really don't have vaccine to give those second doses that were not given, because if we do it will just be very difficult for our system. So we're not able to do that.
Okay. We have about 10 minutes left. I have some specific questions. I'll probably throw one to each of you. Dr. Sennett, here's a question I'm sure you'd be able to answer. Back before the vaccines came out, they were looking for people who had been infected and were recuperated, but to then be able to use the antibodies in their plasma for treatment, correct?
Yes.
Can the same thing be done for people who have not been infected but have been vaccinated? And you said the antibody rate goes up a lot higher with vaccinated patients than ill patients, and use the plasma of these people for treatment in the hospital.
That's an interesting question. No one knows. People have tried it. It's almost in the realm of medical gossip because it's quite uncommon. with the antibody-rich plasma from natural disease, it's unclear if it's truly helpful. So people are looking at the much more active antibodies in vaccinated people, but we have no data yet. We don't know.
Oh, no. Okay. Dr. Kim, you work mostly in the inpatient setting, and can you give us an update on a general, what's a main line of treatment of someone who is infected with COVID serious enough to be hospitalized these days? And also a little help for the community physicians. Is there something we should be doing for COVID positive patients that maybe we're not doing now?
So I think for the inpatient, it hasn't changed all that much. So we give, in the first phase, I think it's very important, for inpatients to assess, their oxygenation, things like that. Generally speaking, we give people remdesivir. If they're in the inflammatory phase, we give them steroids. We often give convalescent plasma if they're seronegative. One thing that I would suggest that physicians do is that if someone is within that first week of being symptomatic and they have a test, particularly if they're medically vulnerable, at high risk, they're diabetic, they have hypertensive, they have a high BMI, they're immunocompromised, I would strongly encourage that, physicians to try to get the monoclonal antibodies for the patients, because I think the data are emerging that if you can get that to patients very, very early on, that you do prevent admissions, you do prevent serious sequelae, things like that. And I think, the studies looked at a lot of all comers, and they also looked, at a range of dates and things like that. But I think our own data is suggesting that it really does have a positive impact, and the earlier the better, that you have a greater impact on preventing admissions and things like that if you can get somebody within, 3 or 4 days rather than 7 to 10 days. So I think that's something that, I think people were waiting because, they wanted to see if it got bad, but then they're often out of the window to get these beneficial monoclonal antibodies. Now, as far as inpatient, not much of our treatments changed. We are evaluating tocilizumab, the IL-6 receptor inhibitors. It seems like the window of benefit is a little bit narrow, and also the treatment is a little bit scarce. So we're evaluating what to do that, but that's a treatment that's got a lot of publicity. It looked like it didn't work, and now there's another study that says it does work. So obviously, as things are published, we reassess, but right now it hasn't changed a huge amount for the inpatient setting.
Yes, I've gotten some questions as a community-based physician on, hey, they want a monoclonal antibody. Dr. Kim, how do I order a monoclonal antibody for my patients?
Well, Tampa General now actually has a way to do community, referrals. I think you can fax in the request. Unfortunately, I should have the Dr. Sinnott or Cancio. You've actually probably had to do it. Do you actually have the number?
I do it all the time.
Okay.
Okay, so if you have privileges at Tampa General, you can put the order in the computer. And actually, I can emphasize to the group and echo what Dr. Kim says. Even transplant patients that have a horrible mortality, over 10% mortality if they get hospitalized, we have managed to not get them hospitalized by using either the Eli Lilly monoclonal or the Regeneron that has 2 antibodies. If we can, we'd rather do the 2 antibodies, but either one, and you can put it in the computer. And if not, I actually went in the Florida Physician Alliance website. We're supposed to have all that information so that physicians could have it. And I'll make sure, I'll take it upon myself to make sure that the Hillsborough County Association gets that information so that they can have, you can either put it in the computer, you can fax this request form. We put it in the Florida Physician Alliance website maybe it didn't get communicated, even though we sent a couple of emails about it, but I'll get it to the Hillsborough County Medical Society so that it goes to all the physicians, because that really helps. The earlier, the better.
Okay.
Those very immunosuppressed or comorbidities, all those high-risk groups, really prevents admission to the hospital.
Okay. Still seems like it's going to be quite onerous to get it quickly to our patients. Dr. Cancio, is there still no place for outpatient hydroxychloroquine?
No place.
No place for it.
Doesn't work, doesn't do anything. Get the monoclonal antibodies for those that need it, or the Regeneron, which is 2 antibodies.
Dr. Sennett, what's your comment on that?
If you don't have privilege at the Tampa General and you have somebody that tests positive within 5 days, and you're not sure how to access the system, because I know Tampa General can be opaque, they can just be sent to the ER with a request that they get the monoclonal antibody infusion, and the emergency department will set it up.
Thank you. That's a good answer. Okay. Let's see, let me look at the people bringing in questions. Okay. Dr. Sennett, there was some media publicity for a while, but I think it's been refuted, but give us a good answer here. As far as even once someone gets vaccinated, transmission of virus was still capable. Is that true, or are these vaccines viral neutral? Does it give viral neutrality and cancel out any possibility of transmission?
That's a $1 million question. We're gradually accumulating data. Recall that, for example, with diphtheria, you can be vaccinated against it, but still carry the bacteria. Okay? And that's true also for mumps and some other pathogens. No one knows for this very tricky virus if that's possible. I've been sort of keeping an eye on myself, and since vaccination, I've been testing myself twice a week just to see. The antibodies really bounced up, and there's been no viral isolates. And I'm also having some patients come in, not an IRB study, but just me observing what's going on. And I haven't found any carriage. I'll be surprised if it stops us from carrying the virus. I would also be delighted. People just don't know yet. Kami may know more, or Margarita, or Doug.
I think in Israel, it reduces transmission. I think where they've done a lot of vaccination, clearly there's less transmission. I think most of us, I mean, I completely agree with Dr. Sennett. We need more information, and the vaccine studies, because they wanted to roll out the vaccine quickly, they gathered some of the data, but it hasn't been, all the testing and stuff like that has not been completely analyzed yet. But I think the prediction would be that some people can acquire the virus, but the viral titers and probably the length of shedding time would be reduced. So therefore, it should be much less transmissible. But the extent of that, we don't quite know yet. And obviously that's the $1 million question. And I think that's part of the reason why we're encouraging everybody to keep on wearing masks and use the social distancing procedures. So probably someone who's vaccinated, even if they can acquire it, they're going to be protected. But obviously we all have loved ones, vulnerable people that we see, and we want to protect our community.
Okay. Some of the participants are giving answers and good questions. Someone wrote in that not only Tampa General, but all the Baycare hospitals also are able to administer monoclonal antibodies through the emergency rooms based on their experience. So don't want to overload one hospital with that. A quick answer, I hope, to a question. Dr. Sennett, you mentioned that you've been following your antibody level after your vaccines, and it's been robust. Evidently, one of our participants has been checking theirs, and 3 weeks after the second dose, no antibodies. What do you make of that? What do they do?
Well, there are at least 6 things that can go wrong with an antibody assay, ranging from mislabeling, blah, 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 blah. I would ask that the person get the test repeated. It would be unusual not to respond to an mRNA vaccine. I would question the antibody test long before I would question the vaccine.
Okay,
And
Exception to that would be somebody that has an immune, we don't know what, somebody that has an immunoglobulin deficiency. Some of the transplant patients get immunosuppression. We're trying to look at those. We're in the process of looking at those, like some of the B cell or T cell depleting immunosuppressants. We don't know what's going to happen. We're looking at that. And actually, we also don't know what happens to somebody that is in weekly or monthly immunoglobulin infusions. We actually are trying to look at a couple of those patients to see what they do. So there are people that cannot produce antibodies, and you know that, but that would be, but the rest should be able to produce them.
so quick recap of that. Redo the test. Number 2, check your immune system levels, antibody immune system. One more question, and then we're going to have a wrap up. Knowing that there's going to be a percentage of people who are vaccinated that can still get the disease, what if someone is positive for COVID after a vaccine? Is there a chance that the vaccine itself can turn the PCR test positive? Anybody want to answer that? Dr. Kim?
The short answer is no, it won't.
Okay, good. So if they're positive after vaccine, they have a new infection. Okay.
Correct. I mean, so the vaccine, I mean, there are some of these attenuated virus vaccines that I think China's developing, things like that. But all the vaccines that are available or will be available or being tested in the US are pretty much only the spike protein. Sometimes it's protein, sometimes it's mRNA. And except for a few tests, almost all of the PCR tests are actually for a different part of the viral genome. So,
okay.
And plus you don't get the whole virus, you just get the spike protein. So you will, if you have a positive PCR test for COVID virus, you know, in the US, you got COVID virus, you do, you know, whether you had vaccine or not.
Okay, thank you. There's been some questions ongoing, and I'm going to go around the panel here. Just kind of, we would like to know your prediction and prognosis. The panelists have been very good about predicting. We're not going to hold anybody to it, but where do you guys see our community 4 or 6 months from now? Do you see us traveling again? Do you see us having sports, dinner meetings, anything like that? Wearing masks still? Dr. Cansey, I'll start with you.
Tough question. I don't know. I have no idea.
Okay, that's an easy way.
I do think that it's going to be a while before we go back to the way we used to be. We have learned that how little influenza we have had this year. We have learned how little RSV for the pediatricians. So perhaps using mask is not a bad idea. And if you really look at other countries like China, Japan, Southeast Asia, in the winter they wear, I mean, you see them all, they wear a lot of masks. So maybe the wearing of the mask will become more fashionable in the US. I encourage it. We have learned how to live with masks now. So that would be, I do think that maybe by the fall, we may be able to do a little more, but I agree with Dr. Sennett. I don't think that this virus is going to disappear. We're just going to have to learn how we're going to have to vaccinate as many people as possible. Once we have 70, 80, probably 80% at least of individuals vaccinated, maybe we'll be able to have more activities, but people will have to be cautious.
What percentage did you say?
80.
80, okay. Dr. Holt, do you have anything to add to that?
No, not really. I'll agree to whatever Dr. Sennett suggests. He seems to be
That's why I went to you first.
best forecaster. But, you know, I think it's gonna be more of the same, should be more of the same. You know,
Okay, Dr. Kim, do you see yourself traveling anytime soon?
I hope so. My son's in the UK. So, I mean, yes, I think probably by, the fall, we're going to be able to travel and be more thoughtful about what we're doing and things like that. But I think it's going to be a while before we're going to cram ourselves into huge places and don't wear masks and do whatever we want.
And cruising.
And I think, people are going to be vaccinated. I think there's also just going to be a lot more exposure to all the different variants. So, gradually over time, people will be more immune. So then it will become safer and we can be, let down some of our guard. But, I think we're going to have to be careful, particularly because we all have loved ones who are vulnerable in some way. They're older, they got medical problems and things like that. So I think, I would love to free up a little bit more, but we're going to have to sort of see what happens. But yes, I would love to travel some more and actually see all of my colleagues at a nice dinner to celebrate surviving this past year, things like that.
For sure.
So I'm hoping for it.
And Dr. Sennett, you were giving your prognosis earlier as other participants were still joining us, but why don't you go ahead and share your thoughts and then we'll come to a close.
No one likes to hear bad news, but I don't think I carry a lot of good news. I think we're going to be masking for several years. I think it'll become part of our culture. I think that's a step in the right direction because it cuts down on other respiratory diseases. When I visit Asia, it's considered part of your community responsibility to wear a mask on public transport. I just think this thing's going to keep mutating and it's going to give us trouble for a couple more years.
Okay.
It'll be like 9/11. I don't think we're going to return to a normal. We're going to return to a different normal.
Okay. Well, there you have it. Thank you all for joining us this evening as panelists and as participants. And for the sake of time, we'll wrap this fifth town hall meeting up. Again, I'm Dr. Mike Cromer, president of the HCMA. And please email the staff if we can be of service any way to you all. Have a good evening. Good night.
Dr. Cromer, thank you very much.
Thank you.
Thank you,
guys.
everybody.
Welcome.